Okay, do you want me to start?
I'll start. Thank you. Hello, everyone. I'm Nika Thuda, Board Chair, WHDF, Women and Health Together for the Future. It's my pleasure to welcome you all. I'm not sure to say good morning, good afternoon, good evening to all. I'm not certain from where you all are. However, welcome to the webinar. And very briefly, I think I'll give you about WHDF, who we are, and when we started ourselves, that was way back in 1991 as part of the network, of an international network. And now and then later we became a separate entity in 2019 and registered ourselves in in Cape Town, in South Africa. So we work very closely with Western Cape Town University, and we have our office there. And we'd like to welcome you all and just make few announcements that you will find a link to our website, and we invite you to become our members. You'll find different categories of membership available, and whatever is suitable, appropriate for you. We would like to see you engaged with us, and we'd like to see ourselves also benefit from your expertise and your research that you are engaged with right now. Also, another small announcement, you will find a link very soon, a feedback link to our webinar. And please kindly fill it's a very short form, feedback form. And immediately after the webinar, you will receive a certificate of participation. So I hope you will be inspired by the talk today, and I will today's speaker is Bomikazi Lupindo, and of course she is a researcher and a clinical psychologist by profession, and I won't do justice to her just by saying that, and I would like to invite our executive director Michelle Endipajan to please introduce our speaker for today's webinar and of course elaborate on what she's going to talk about. Thank you so much and look forward to your presence in this webinar. Michelle,
Thank you, Nika. Thank you. Good afternoon, everybody. A warm welcome to this webinar. I want to say a special thank you to our Dean, to Prof. Padmanabhanoni. She's here today because Bomikazi is her student. So welcome, Anita, and it's so lovely to have you here. Welcome to all the colleagues. There are quite a few I see from UWC and from South Africa, so it's really nice to see you all, and to all the other guests that are here. I'm very excited to introduce Bomikazi. I met her very recently and we had one or two chats, but I'm very excited about her work. And so she's a clinical psychologist and she's currently completing a PhD at the University of Oxford as a Rhodes Scholar in South Africa, from South Africa. She has clinical experience working with children and families, as well as with adolescents and adults within public health and correctional systems. Her research focuses on developing interventions that mitigate the effects of adolescents' exposure to community and school violence. Bomikazi believes that mental health has the power to bring about critical consciousness as well as emancipation. As such, she is passionate about improving the state of mental health services in South Africa and the world. And she also co-founded a non-profit mental health organization called Mind Matters NPO, which provides mental health literacy and advocacy, makes mental health services more accessible through providing free online lay counseling services and school-based mental health programs, especially for young and vulnerable groups, as well as she also provides mentorship and volunteering opportunities for those interested in the field of mental health. Bomikazi brings with her an empathic, thoughtful, and collaborative approach to engaging communities to build impactful and sustainable solutions to social issues. Over to you, Bomi. You can share your slides now, eh?
Hi, everyone. Thank you so much for having me here. Hearing that Anita's here actually makes me a little bit anxious because she's my supervisor. So anything I say is also kind of reflecting on some of the work that we're doing. But I look forward to sharing some of my research with you guys, but also just like learning from the space as well, and helping me kind of think about ways of moving forward in this work. So I am just going to share my slides. Give me 2 seconds. PowerPoint share. Okay, so continue to share? Are you able to see that?
Yes, we can.
Yes.
Eh?
Okay, that's perfect. So again, good afternoon, everyone. My name is Bomikazi Lupindo. I am a clinical psychologist, and I'm also a final year PhD candidate at the University of Oxford. My research is focused on understanding the impact that exposure to community and school violence during early life has on mental health and adjustment challenges that people experience later on in life, with the focus of trying to think about what it looks like for us to build context-relevant interventions. And today I will be sharing that work with you. And before I get into that, I thought it might be nice to get to know me a little bit more, but also some of the stuff that informed my interest in this work. So these are pictures of me at various stages of my life, but I think they are great pictures that kind of reflect who I am. The first one has me there as that little inquisitive bumblebee that had a spark in her eyes. I've always just been like a really curious young person and just wanted to understand things and people, which I guess led me to where I am today. A huge part of my identity is I'm South African, but I'm also Xhosa. And I think that's an important part of me. And then this is me in Oxford. And yeah, so that is something that informed part of kind of the journey that I am. But I think the most important thing that I thought about when I looked at these pictures is that something that these pictures do not depict or communicate is that when I was 5, I actually witnessed an attempted rape that happened outside of our home to my sister. By the time I was 10, we had had 2 break-ins into our home while we were inside. And by the time I was 16, I had been robbed by 4 men who held me at knife point and tried to take my belongings. And these experiences are unfortunately not unique to just me. They are lived realities of many young people in South Africa and many other low and middle income countries. From a professional perspective, I've worked both in academic and community clinics. I've worked in psychiatric hospitals and general hospitals, but I've also worked in correctional systems. And one of the consistent things that I was observing in those spaces was the fact that trauma and childhood experiences of violence were quite common experiences. And for a large part of the people that I was seeing within those spaces, they were presenting within those systems because of these experiences that they had in childhood. And it's through working through these systems that I also became aware of just how the current approaches to care are just not meeting the high demand and the high need, and helping serve the people that we're seeing in these spaces. And part of that is I tried to respond by establishing a nonprofit organization. But even within that space where we're using task shifting approaches, which is primarily training people who are non-mental health professionals to deliver mental health support under supervision of a qualified mental health professional, I just still didn't have the capacity to service the amount of need that was there, which is the thing that then led me to go to Oxford. And I hope by the end of this presentation, you will get a clear understanding of why I went that route and what it is that my work has focused on. So one of the significant issues that we are confronted with is that young people in both South Africa, but also other African countries, they are exposed to high levels of violence. And unfortunately, these violence experiences result in significant impact in terms of their mental health. It results in some of them becoming perpetrators of violence. It results in school dropouts, which affects kind of employment opportunities. And this is a significant concern because there's just not enough support to be able to support these young people exposed to these experiences. And even though we have this clear understanding that trauma and exposure to childhood adversities can be something that we can help support young people with, and help them work through it so that they don't have these negative outcomes. We just don't have enough mental health professionals to be able to provide support. So one of the significant gaps that we experience, specifically when we think about low and middle income countries, is that even though these are the regions that have the highest need due to the high levels of adversities that we experience and the limited resources that we have in these contexts, but also where the largest, youngest population resides, there's still just not enough research that's focused within this context. And also, most importantly, even though we are seeing that we're having these challenging experiences, and we are aware that trauma and its related challenges is not necessarily something that everyone kind of has the similar kinds of outcomes, we are not just getting enough research that's context specific that can help us think about some of the ways in which we can develop context relevant interventions. So part of recognizing that not everyone who experiences some kind of adversity or trauma then has negative outcomes has led quite a lot of researchers in trying to understand, okay, so what are these factors that are able to mediate or moderate these violence experiences or adverse experiences that people have that can help them either not have quite severe outcomes, or us thinking about what it looks like for that to not progress into even worse impact when people have had these experiences. And although researchers are doing research in this area, one of the biggest challenges that still exists is that some of the factors that they are identifying are not necessarily modifiable factors. So they would identify things like gender, the age at which the violence exposure happened, the number of violence experiences that you've had. But a lot of these things aren't necessarily things that you can change or inform some of the interventions that we're building, but also in instances where they do identify some of these modifiable factors. So for example, things like peer connection, parental warmth, school climate, resilience. They don't also speak about some of the psychological processes that are involved that help bring about these mediating or moderating effects, and therefore it impacts our ability to then build effective interventions. The second thing that we currently have a challenge with is that we have a big reliance on public health systems, or more professional or heavy reliance on mental health professionals to be the ones that are delivering the support. And as I mentioned in the previous slide, that we just don't have enough mental health professionals to be able, or even just the resources within these contexts to be able to meet this high demand. In South Africa, we have waitlists that go up to 6 months that people are waiting to see a mental health professional. And when we think about what it looks like in high income countries where a lot of the research has been done in terms of what outcomes kind of result from these wait lists and these referrals, we find that actually up to 40% of these referrals actually go unseen and they get closed before they actually get the support that we need. So we've also begun to see a bigger growth in terms of recognition of the kind of impact that more community-based programs can have, and using things like task shifting models, where we train people who are non-mental health professionals to deliver support, that they're having a positive impact because it shifts from just relying on the mental health professionals to kind of having a larger group of people that can deliver support, but also most importantly, making the support accessible to the people by bringing it into these communities. But again, one of the challenges that we are seeing in some of these models is that there might be trauma-informed support, but they're not trauma-focused. So they are the kind of support programs that recognize that people can come into our spaces and coming in for support and have a history of trauma. And therefore, how we deal with them and work with them needs to hold this in mind and make sure that it is able to support them, bearing this awareness in mind. But it doesn't necessarily target the actual trauma itself, and try to work towards helping people be able to process that trauma in the same way in which kind of maybe seeing someone that's a specialist or someone that's like particularly a mental health professional can be able to provide that kind of trauma-focused support. And then the last bit is thinking about the current theories of kind of trauma and trauma-related outcomes that on the one hand, we recognize that these models are actually successful in treating depression, anxiety, and even PTSD. And there is clear evidence that they are showing that communicates things like how cognitive appraisals, memory processing, and some of the coping strategies that people use, that these are important predictors from some of this diagnostic distress that we then see following trauma. But a big part of this is that treatment and work that's focused from these models tend to address these challenges or these diagnoses as independent diagnosis, whereas we know that PTSD, anxiety, and depression, they actually tend to be comorbid rather than occurring from like an individually or separately. They tend to be quite comorbid conditions, and we just don't have transdiagnostic frameworks that help us better understand trauma as being a mix of these challenges rather than us understanding them from like single trauma models. The second thing is when we think about using these diagnostic models, we tend to use them from a framework of thinking about the big letter T trauma, which is like this big traumatic or acute traumatic incident that's now happened, which is part of the criteria of you getting a diagnosis of PTSD. And therefore, it's through these models that we then decide who gets treatment versus who doesn't get treatment. Versus when we think about low and middle income countries, that it's not just the acute event that young people have to deal with, but it's the smaller kind of or the smaller trauma effects that they also have to deal with. So these include things like poverty, relational friction, and other structural inequalities and inequities that significantly impact their well-being. And this is the same for depression, right? That we have the larger depression, which is the cluster of symptoms that when you have 5 or more of those symptoms for over 2 weeks, then therefore we can diagnose with depression, and therefore that triggers us to then create the support system for you. Whereas in actual fact, more milder symptoms that don't meet clinical diagnosis are things that significantly impact young people's well-being. The other thing that has to do with more cognitive models that we're currently using is that they tend to equate symptom reduction with being equivalent to well-being. So if we help you kind of work on some of these cognitive appraisals and also work on some of these kind of trauma memories and how you cope with them, then we assume that by reducing the symptoms themselves, we then are able to get you to have better outcomes. But this is generally not the case, that symptom reduction doesn't always equal well-being. And part of the project was to better understand what it might look like for us to build these transdiagnostic frameworks and then use those to inform us building interventions that are context relevant, considering also the resource limitations that we have in these spaces. So the structure of my actual PhD project was then, the first bit was a systematic review, trying to understand existing knowledge, and again, mapping up some of the immediate and longer term consequences of being exposed to violence, but also identifying what we know about the mediating and moderating factors that contribute to this, and whether or not we understand the psychological mechanisms that are involved in this, which was the main gap that we saw in this research. Second was a qualitative study with young people in South Africa that mainly aimed at understanding more in depth their experiences of violence, their immediate impact, but also the longer term impact this has had. But most importantly, things that made it better or worse for them, and how we can begin to use this understanding to build on more quantitative methods to further investigate this. And then we then moved on to doing a quantitative study that investigated the outcomes we found from the qualitative study. Sorry, I just noticed that when I created the slides, it kind of rotated the design of the study. So it was first this the systematic review and then the qualitative study. Hi, can you still hear me?
Yes, yes, Pomi, you're all good. I
Yeah.
think there's somebody's mic is on.
Okay, sure, no problem at all. And then we did the quantitative study to further investigate this, which then informed the development of our intervention. So in terms of the qualitative study, the main findings that we found there were really consistent with what we already know in terms of cognitive models of trauma, both thinking about the depression perspective, anxiety, but also PTSD. That the main thing that was maintaining challenges for people or made it worse for people is a continued sense of feeling unsafe, appraising or perceiving that these kind of reactions that they were having, which were normal trauma reactions, are actually communication that or indications that they were somehow damaged and are now defective because of these violence experiences that they've had. And they anticipated that people would actually reject them because of now having these experiences, which just made it challenging for them to be able to cope. And then most significantly, which is something that hadn't been kind of investigated in other cognitive models before, is the impact that kind of betrayal had on them, so that people couldn't be trusted, that these violence experiences were either perpetrated by people that they knew or people who established a sense of trust with them and therefore betrayed them in that moment. And an example of this could be like someone coming up to you and seeming like they genuinely care and worried about your well-being. And then after that, they immediately mug you. So they found those experiences to actually be a lot more challenging for them than if this wasn't someone that they somehow established some level of trust. So the way in which they tended to then cope with also connects to some of to the current understanding of cognitive models, is just they either dealt with it with either avoidance or aggressive behavior as a way of trying to protect themselves from further victimization. But the important thing that these young people identified is that the main thing that they felt was actually quite helpful for them is feeling as though they were not alone in these experiences. So this is a combination of knowing that other people have went through similar experiences and we're having similar challenges, but also even if other people didn't go through this experience, that sense of community and connectedness and feeling as though they would still be accepted by people, even with these violence experiences, was an important thing that they found to be helpful for them. So we then used the findings that we had from the qualitative study to translate it into which psychometric measures can we use quantitatively to further help us understand these psychological mechanisms that are involved from violence experiences. So the sense of continued threat, we use trauma memory and rumination scales to investigate that in the quantitative study. We then also used the notion of being damaged and defective, linking it to more mental defeat, which is also quite connected to the kind of grief and loss that we tend to see in people who are presenting with depression, and focusing specifically on what mental defeat looked like at the immediate time of the trauma. But also the sense of people could not be trusted. We used a betrayal sensitivity scale. And then when it came to thinking around avoidance and aggression, we looked at more characteristic or demographic factors that characterize the sample to see, okay, so if we look at the people who are presenting with symptoms versus those who weren't presenting with symptoms, what was the nature of their relationships? Were they people in romantic relationships or in some kind of partnership that could be kind of a moderating factor to them not having these negative outcomes? And taken together, these scales that we were using would then be able to look at some of what the trauma models are focused on, but also considering what it looks like to include this and integrate more depression and anxiety related kind of understandings, as we know that these are comorbid presentations. So from this, we were able to get quite a clear understanding in terms of what it is that firstly maintains PTSD, but also the distinguishing factor that contributes to healing. So from kind of some of the research was speaking about the age at which you have violence experiences or the number of violence experiences that you have, then is the thing that tends to lead to PTSD. But when we added the factor of mental defeat, which again is this kind of inherent sense of loss of even sense of like humanness that happens for people when they immediately are exposed to that violence experience, be it sexual assault or experiences of robbery, we tended to see that at an acute appraisal level, that was the thing that was more immediate that then caused them to be more likely to develop PTSD. And then at a more proximal level, which is like the main things that then maintain kind of these outcomes that we see, be it it's PTSD, anxiety, or depression, it tended to be linked to the trauma memories that they were experiencing, but also how they were responding to these trauma memories, which again is tied to the kind of identifications that we already saw from some of these cognitive models. But again, a significant contributor and a significant predictor for PTSD was also just this level of perceived kind of betrayal that they experienced during the violence experience. And then when we looked at well-being, so even though we put the exact same model to try and see whether mental defeat, trauma memory, and rumination were the things that then predicted well-being, we were then able to see that actually they lose their predictive power once we then integrate this betrayal sensitivity factor, which then again tells us that the thing that actually makes people well after violence experiences is not necessarily the reduction of the symptoms themselves. It's again how we then reestablish the sense of connectedness, the sense of trust that then becomes fragmented when we are having these violence experiences, which then brings us to a more diagnostic model that we can think about in us building interventions that are specifically focused on trying to help people recover from these violence experiences, but also considering the kind of context that we are working in, which are, if we think about South Africa, where this research was done, that we're more of a collective society versus where these trauma models are developed. They tend to be more individualistic communities, but also most importantly, they tend to use adult populations to kind of build the research has built from adult populations and not necessarily child populations as what the interventions we are trying to kind of build or for. So based on these models, we then kind of took this understanding from the research to then think about what does it look like to build an intervention and what are the things that the intervention would need to address when we are thinking about support for young people in these contexts. So we thought about the important factors that we've seen, that mental defeat, that even though it's more at an acute appraisal level at the time of the violence experience, and it's an immediate impact, we need to think about what it looks like to actually kind of validate and integrate these narratives that people have and help them recover from this sense of powerlessness that they felt from these violence experiences. From a trauma memory perspective, which is a lot more proximal in terms of the ongoing challenges that young people are experiencing, and focusing specifically on memory reconsolidation and making sure that the material in the actual intervention itself is addressing this. And then thinking about response to intrusions, which again is a lot more proximal in terms of maintaining more trauma-related psychological outcomes, and what it looks like for us to build this metacognitive awareness, but also equip them with the necessary tools on how to respond to these intrusions in a way that actually helps them cope better, rather than kind of creating this sense of stuckness that they continue to feel. And then the last bit was us thinking about what does it look like to build an intervention that also considers this betrayal sensitivity, which is the relational impact that these trauma experiences have on young people, and what it looks like to re-establish that sense of trust and more interpersonal relationships, helping them feel a lot more reconnected and reintegrated into the kind of communities and connections that they have. And this became the blueprint for which we then kind of developed an intervention that specifically tries to address these trauma reactions. So in terms of the actual intervention itself, the intervention is a community-based approach. So the intervention is aimed at kind of bypassing some of the kind of clinical limitations that we tend to have when it comes to getting support from mental health professionals. So what we do is we train people who are either community care workers or community care facilitators, and we train them with their intervention, and we've made it low intensity enough that it's actually material that's accessible to them. And then we provide them with training that's specifically focused on addressing these trauma reactions that we are seeing in young people. And the curriculum itself is aimed at including this more transdiagnostic approach in terms of how we structure the actual sessions themselves. And we are then kind of doing a feasibility and acceptability study that is now being piloted in the Western Cape with two organizations that are supportive towards young people. One is more of a mental health organization, and one is more broader general community-based support for young people. In terms of the intervention itself, the intervention is an 8-session structured intervention that focuses on using more experiential approaches. So the sessions are structured by having more of a psychoeducation bit that helps young people kind of understand trauma and the impact that it has on us, but also how that translates into the current challenges they have. It has a reflective bit, which gives young people an opportunity to kind of think about and reflect on their own experiences and how this might translate to them. But also we have more experiential tasks, which include things like body maps, rumination comic strips, which are less verbal tasks that we use to help them be able to process some of these traumatic experiences they had, but also using the same tools to kind of build a sense of agency in them reclaiming their lives and being able to build after this aftermath. And the intervention itself is delivered in a group setting where we have 6 to 8 young people, which is the connective bit and reducing the sense of isolation that young people might feel. So it's delivered in a group setting, but also it addresses the resource scarcity perspective, which is we are now able to deliver this intervention with a larger number of young people, and we don't necessarily rely on a mental health professional to have to be there. And the mental health professional just comes in a supervisory and supportive role for the facilitators. And in terms of the next steps, that right now, like I mentioned, we are currently piloting the intervention itself, and we've received quite positive feedback in terms of the facilitators who received the actual training. So we've trained 12 facilitators who are now in the process of delivering the intervention with young people. So based on what we are seeing in the intervention, we would actually like to then build on this work in terms of the postdoc program that Michelle and Anita and I are involved in. So that would then kind of look at continuing to build evidence for this specific intervention and looking at the South African population. And then the ultimate goal of that is kind of moving that to more kind of adapting it for similar context to South Africa, and specifically focusing on low and middle income countries, but also most importantly, thinking about what it looks like to translate this into using more digital training platforms to be able to deliver the training, but also thinking about scaling. As right now, the primary way in which we deliver the intervention is through in-person training sessions, which are often quite time-consuming, but also it limits our ability to have reach. But yeah, that then brings us to the end. But yeah, thank you so much for landing in here. And I would definitely love to hear kind of thoughts, any ideas that I might want to kind of think about post this, and any other questions that you might have.
Thank you so much, Bomi. Wow, that was absolutely amazing. In the chat, people are also confirming that. And I think one has an appreciation for the importance of your work and just how huge the problem is within South Africa, and I'm sure globally as well. So, colleagues, the floor is open. Any comments, any questions to Bome? If I don't see a hand, God, please just help.
Hi, Michelle. Can
Hi
I?
there, go for
Yeah,
it,
hi, hi.
Kamani. Yeah.
Hi. Thanks a lot for beautiful presentation. And I'm from India. I'm also working in the
Mhm.
area of emotional support. Me and Samriddhi, we are both working for a emotional support and suicide prevention helpline. And the fact that there is lack of mental health care professionals and
Mm.
training them. I mean, I could see a lot of similarity of what you are going through and what
Mhm.
we in, India, and I can almost say for Pakistan and South Asia, we all are going through. Uh,
Yeah.
in the beginning, you talked about your experience in prisons as well. So I
Mm.
just want, since we have also started working, I wanted you to share more.
Mhm.
How was your experience in prisons, and did you feel any difference? Were it with the male prisoners, female prisoners, or the juveniles? And what are the psychological issues and traumas you see in there? Yeah, thanks.
Sure, sure. Thank you so much for that question. And so one of the things that I actually didn't include in this presentation is part of my PhD project, which made it a little bit too big. So we're still doing the work, but also having it on the side instead of just having it as part of the bigger project, is we actually did the same quantitative study that we did in South Africa. We also did it in India. And part of why we did that was also we wanted to see whether are there any kind of context and cultural differences that we are seeing in quite similar countries? So both low and middle income countries with colonial histories, but also most importantly, more collectivist approaches to how our communities exist. So that's definitely a space in which we are kind of looking at if we are kind of adapting the intervention, what it might look like to translate it specifically in India as well, especially because that's a place in which we already doing this work in. But with regards to, I guess, the correctional system that I worked in, it was primarily an adult facility. And also pretty much everyone that I saw in that system were kind of repeating this similar kinds of experiences, that they were exposed to either violence within their homes or violence within their communities. And their way in which they either coped was either they became part of gangs as a form of trying to get protection, which then exposed them to actually more violence, but then they also became perpetrators of violence themselves. And part of what happens within the correctional system is when you get sentenced, they actually prescribe specific programs that you're actually supposed to do as part of the corrections, so that when you go back into society, you are able to kind of reintegrate in a way that helps heal this part of you that caused you to cause the corrections in the first place. But the biggest challenge that I saw there is what was on the policies and what was on paper wasn't necessarily what translated to what was happening within those systems. And even the interventions that were being delivered there were not necessarily evidence-based interventions, or even the people delivering them who are not mental health professionals were actually, they didn't have an understanding of what it is that they even were delivering, right? Which is also why I then kind of wanted to do that kind of work, because the main interest was, what does it look like to then build these interventions and improve them within correctional systems? But even thinking before getting into correctional systems, what does it look like preventing young people from getting into that system in the first place, which is what this part of the project does. But that's definitely a population that I have a big passion for. And I still want to kind of look at what it looks like to kind of make sure we have evidence-based interventions for those spaces.
Thank you
Um,
so much. Thank
yeah,
you.
Judy's hand's up, and then there's a comment in the chat that we can come to after Judy.
Sure.
No, no, take the comment first, Michelle, in the chat.
So look, Lukanya is saying he's not sure if he saw correctly, but he thinks you showed that the broader context was weakly associated with the pathways. If that is correct, what contextual factors do you investigate?
Okay, so I think Lukanya, sure. I think you unmuted. Do you want to add to that?
Lukanya, you want to go for it?
Yeah, thanks, Michelle, and
Sure.
thank you so much for the presentation, Bomikazi. It was lovely. I think it was one of your in one of your slides where you were showing some of the pathways in the relationships, and you were showing, I think, some of the more individual factors and contextual factors in their relationships to the outcomes. And you had some, you expressed some p-values there, and if I'm not sure if I'm remembering correctly, but it seemed that the contextual drivers were weakly associated in those pathways. And I was just trying to understand what
Sure.
that represents and what did you
Yeah,
measure?
yeah. Sure. So it's actually quite the opposite, Lukanya, to say the contextual factors actually matter, right? So if we think about like the trauma models, and maybe I could just use the PTSD model, that it says you have this acute experience and it's the nature of the memories themselves and how they present, and you responding to them, but also how you appraise some of these kind of reactions you have, be it it's arousal or those kind of factors that then influence how you then respond and cope with them. And that kind of keeps you in a loop because you'll cope either by avoiding it, avoiding specific situations because they either trigger smells or memories or certain feelings, more visceral feelings that you have. That is the loop that keeps you within the PTSD itself. But what we also seeing in this specific kind of population is that more contextual factors are important, right? Which is who did the violence in the first place. So this sense of kind of fractured trust and relational bits were an important part, which is what the perceived sensitivity to betrayal measure was also looking at. So that's an important part that we need to consider when we are thinking about these models, that it's not necessarily just, yes, those are a big part of it and it maintains the trauma, but what we're also seeing that fixing that and addressing that doesn't necessarily restore well-being for people. Because when we looked at the second model, and I think this might be the model that you were referring to, when we were looking at the well-being model, we put exactly the same psychological mechanisms that are identified by trauma models, but also anxiety and depression models, to see whether does accounting for that then give you well-being. But what we saw is actually the main thing that still remains statistically significant and the other psychological mechanisms were not significant in well-being was the betrayal part, which is more context specific and I guess speaks to the population. So I hope that answers your question. But there's actually a paper, another PhD project that I came across, I think about 2 weeks ago, that was also done in Oxford, that was looking at how do we begin to understand the cultural influences that even begin to explain these cognitive models of trauma and influence how we appraise these triggers that come up for us, which is often something that the cognitive models themselves do not actually speak about.
Thank you. Thank you, Bomi. Judy, you might go.
Yes, thank you. Actually, that was helpful because first of all, this is great work, and I want to commend you highly. The whole notion of individualistic approaches to most mental health conditions is not a very solid one.
Yeah.
And has, I would say, a rather bad history in countries like mine. So, but I totally understand the approach, the community approach. I've certainly worked with it my whole life. But what I'm trying to figure out is how the trauma focused curriculum addresses this issue of betrayal and trust when it is in an environment when this is likely to happen again.
Yeah.
So we're not talking about a perfect world in which you deal with your own, experience and then come out and face it. Now you're back in that very same world that created the situation in the first place.
Yeah. Okay, so I'll start with the trauma model itself and specifically for PTSD, right? So one of the issues that we have is that it in just the diagnostic criteria itself, it says that trauma is a past event, like the acute trauma itself is in the past. So therefore, it's assuming that we are helping people heal based on something that's in the past. They won't see it again. And we are saying, what does it look like to reestablish that sense of safety within yourself, that psychological safety, so that you can move and exist in the world and see that there isn't a trauma anymore, right? So whereas in actual fact, in our context, that's an ongoing thing. So it's not necessarily that we helping you feel safe. It's an unsafe environment. So what does it look like to establish internal safety while you feel safe outside, right? So a lot of the research was also trying to look at that to say, hey, should we be treating people who have these experiences and are still in quite acute traumatic experiences? Is that even fair? Does that even make a difference for them? Or are we just positioning them in a place where they get re-triggered more and more and more, and therefore they're not able to cope, right? But what we're finding in the literature itself is that actually, even though people are in these continued senses of being unsafe, they do benefit from getting trauma interventions, because what that does is it reestablishes that psychological safety internally, but also it equips you with the ability to see that, hey, actually, you coped with that situation, you survived that. Whereas the thing that keeps us in the trauma is that it feels like we exactly in that situation and we feel mentally defeated, that we now damaged, we don't have a future because we've had these experiences. So the thing that we're taking away is not necessarily that suddenly your environment is safe, is how do we help you, even after this experience, still be able to develop that internal resilience that helps you see that, hey, you have the internal resources, but also in what we are now trying to step into, the external resources in terms of your community to be able to cope, even if you were to encounter another violence experience in your environment. So what does it look like to not, even in the safety of, well, safety being, again, a very abstract concept within South Africa as well. So what does it look like to create that psychological safety within yourself so that you don't stay in the actual trauma and the reactions of the trauma itself, but also most importantly, helping you recognize your ability to be able to survive it in a way that equips you with the resilience you might need should you then experience another traumatic event. So that's the first bit, specifically with the violence exposure. The second bit is the building of the sense of connectedness and sense of community. It's not necessarily to say trust everyone around you, but to trust that the people that you do have, there are networks that you can lean on that can help provide that support and containment even after you've had this violence experience. Because some of the experiences that the South African population was describing was the thing that made it difficult for them, and they actually isolated a lot more, is worrying that other people would either blame them or reject them from having this violence experience. So it's not necessarily kind of saying your environment is safe, but where do you find that safe refuge that helps you cope better with this adverse kind of environment that you're in? Because that is something in an immediate sense we can't necessarily change for you. So is there a room and space for us to help you reclaim your life and build a life that's meaningful for you, even in the face of the level of adversity that you do have in your environment?
Thank you. Thanks for that. There are two questions, Bomi, in the comments. Is there a change in incidence of violence over the last few decades, or is it the same?
I think
Hard to say.
That's a hard question, but we are consistently kind of seeing an increase, in some of the violence experiences that we have, and this is not only just unique to South Africa. We're also seeing it in the UK, that more and more young people, there's a lot more knife crime, there's a lot more violence perpetration that happens between young people. So from that perspective, we could definitely say we're seeing an increase. And a huge part of that is if we are exposed to this violence in our communities, of course, like the violence itself, if you think about like systemic issues that are happening in contexts like South Africa, it's a broader systemic issue, and violence itself is a symptom of more broader systemic issues. So I guess part of the intervention is thinking about, okay, so we're addressing the actual symptom itself, but we're hoping that part of what we're building here is evidence of saying, hey, if we help support these young people, we can keep them in school. But also, if we keep them in school, we also need to think about what it looks like for them to have these employment opportunities and these employment prospects that then don't put them in the exact same kind of situations of then perpetrating violence for economic reasons, and being within context of such severe deprivation that it feels like that's the only kind of way to go about. And the unfortunate thing is that the people who are also most deprived are also the people who experience the violence the most, because that's the communities where the violence itself actually happens, which I think is quite an unfortunate kind of cycle and loop that we are hoping to begin to break.
But I also think in the Western Cape, we're faced with such huge levels of gangsterism.
Yeah.
And that's definitely on the increase. So I think that the forms and the types of violence may have changed, but the incidence for me has definitely increased. That's just my own view. Yeah. Then there's another question. Are you getting any government funds or support for the work that you're doing?
Unfortunately, no. I think that's also been quite a challenge, which is also why for me it just feels like the best way to even try to go about continuing this work is from like a academic also perspective. Yes, it builds the evidence of it, and it's definitely monitoring and evaluation that we already do within the NPO space, but there's just not any funding for it. So even now, the funding I get is to have me in Oxford to do a PhD. So any field work that I then had to do, I had to kind of try figure out what it looks like to even begin to do the field work in South Africa. So we are hoping that we at least secure grants for the postdocs so that we can be able to continue with this work. And I'm hoping that through building this evidence, this is also the thing that we can lobby governments to say, hey, actually, like, we're seeing the impact that this intervention is having. And therefore, this is something that needs to be integrated into these programs and into these systems that the government has as part of the offering that is given to them. So unfortunately, right now, no, we aren't funded by the government in any capacity.
Yeah, just a comment from my side. I just came back from a visit to the University of Pretoria, and what I found very interesting, you were talking about lack of opportunities and dropouts and so on. So what they're doing is they're focusing a lot on the pre-university academy to give young people the opportunity. Not just to catch up, but to be able to excel so that they can have access to tertiary level education. And then somebody else did a presentation almost talking about we capturing them too late during adolescence and high school. It was almost a perspective of from the cradle to the grave, starting with ECD, building those foundations. I was absolutely fascinated. And then almost the crime fighting that they basically involved in Hatfield with the University of Pretoria, with the private security companies, with SAPS, and how they go about to try and prevent violence and crime so that the environment is safer for the students. So that was a huge eye opener, because sometimes it's things we don't often think about. You know, we kind of take it for granted that your students are able to commute safely to school and back, and it's not the case.
No, I completely agree with you, Michelle. And also part of this intervention, it's a very small part of the issue that we need to address, right? So we're starting with adolescents, and we specifically picked that specific population simply because of two things: that they're in a transitional period into young adulthood. So the demands that tend to be placed on them, they actually kind of significantly impact them a lot more if they don't receive that kind of support. But also, like, a lot of the literature was also speaking about just the level of cognitive awareness because of their developmental stage makes things a lot more harder for them. Whereas like younger children, because they don't even have like the emotional vocabulary to even verbalize the experiences, it's not necessarily that they're not impacted more, but we're seeing a little bit more of these young people kind of externalizing and internalizing a lot more than younger people. But the whole purpose of it is to think about what the intervention looks like in adapting some of the content to younger populations, but just starting with this population to see what kind of impact it has on them.
Yeah, I think there's one more hand. Probably have time for another question. Nakupumla, you may go.
Hi, mommy. How are you?
I'm well, thank you, Nakupumla. How are you?
I'm good. I'm good, mommy. I'm Nogo Pullman from UWC under the Health Data Analytics. My question is, mommy, have you considered or look at the issue of over-counter medication? Because most of young people are in denial of the anger issues. They like to take the short route of going to maybe to buy for over-counter medication to calm down, and also to use of substances like alcohol for dim the trauma that they went through. That is
Yeah.
also the issue that young people that are facing, especially here in South Africa.
Yeah. No, I completely agree. And I see there's another question there to say the association with alcohol. So that's part of the coping strategies that we were able to identify. So in the actual presentation itself, I don't kind of specify what avoidance even looks like, right? So avoidance looks like that kind of numbing, right? So we can avoid by not going into an environment or avoiding specific people, or we can avoid the emotions themselves. So if I drink alcohol and I numb or use certain drugs and numb these feelings, that's a form of avoidance. But the problem is, because it also kind of impairs your ability to kind of process and think about the things that you are doing, it does put you at a lot more risk of being a victim of further violence perpetration or perpetrating violence yourself, because now you're enacting things and you can't even kind of control the kind of behavior you're doing. Whereas on the other hand, that you're right, that medication, I think that's a part of like a treatment avenue. But based on how you're describing it, Pumla, that it's almost as if I express this and I say that I'm struggling in this way, it's quite difficult for people to either take it seriously or people to kind of think about what an intervention looks like. And therefore, if I take medication, that's also an indicator of distress and trying to manage the feeling, but it doesn't necessarily get to the root cause of helping you kind of process that. So we're dealing again with the symptom of it and not necessarily kind of the foundational bit that caused that symptom to begin with. So those are also like the kind of things that we're holding in mind when we are thinking about ways in which young people are coping, and how we can then think about what it looks like to create a space and safe kind of dialogues that exist, that help kind of destigmatize this. So it's a bigger piece of work that I guess we touch on in different ways, whereas the intervention itself, I guess, it tries to address exactly what you were saying, to say, hey, we recognize that something happened to you and it's having an impact to you, and we opening up a space and room for you to be able to process that, but also to not do it in isolation. So you can actually see that people who go through similar experiences, which is trauma and violence as a whole, it doesn't necessarily have to be the exact same violence experience, what it might look like to begin to support those young people in those spaces and hopefully destigmatize just even struggling after violence experiences like this.
Yeah. Bumi, thank you so much. This was so insightful and so helpful. And you can read the comments in the chat. Everybody saying thank you. You're passionate about what you are doing. And we need more of this. So thank you very much. Over to you, Nigat.
Yeah. Okay, well, thank you so much. I think we all enjoyed your presentation. It was very inspiring, and we hope you can implement your work. That's important, how to shake the policy makers to do something, because when you talk about poor public health system, then the policy makers come in, and they have to resolve that issue on an immediate, basis. I also like your idea about the curriculum. I think that is very important, and I would really like to see whether we can generalize it to other contexts. How to establish, implement, can it be generalized? How can WHTF can help in that, group to other continent region? And because this is not only South Africa issue, this is a global issue. And I think many of us don't talk about it, but then it's not to be hidden and it's not something that we can hide anymore. So thank you again. Thank you, Michelle. And to all our participants, it was a great talk, and your questions were also inspiring.
Thank you. Thank you very much, everybody.
So much,
Again,
everyone.
look
And
forward
thank
to
you so
having
much
you
for the
again.
kind words in the comments. I see all of them. Thank you.